So today we are going to explore the surgical anatomy of upper eyelid, as it's a very important role in all the facial expressions, as well as the upper eyelid, which regulates the light entry. It's protecting the eyelid from any injury, and also it acts as a shutter of the eyelid. So let's discuss about like the importance, landmarks, the layers, lid glands, eyelid margin, nerve supply, and blood supply. So surface landmarks are you can see the upper eyelid crease, and it has like in Caucasian the crease is about 10 to 12 mm in females, and in males it's 8 to 10 mm in males, in females. So in Asian it's difficult, like it's different from Caucasian, where in Asian eyelids it has like 4 to 6 mm in males and again 6 to 8 mm in females. So you can see the superior palpebral sulcus, where the lid margin started from the upper eyelid margin. From this is called the superior palpebral sulcus, and again we need to see the cover of the what is the lid margin, which covers the cornea, which is 1/6 of the cornea, and the lower limbus, which is covers the inferior limbus, which covers the inferior part of the eyelid. So again we have to see the palpebral fissures, which is in the length, this is 8 to 10 mm, and in the width is the width is 8 to 10 mm and the length is 28 to 30 mm. Now we can see the lateral canthus, which is 2 mm higher than the medial canthus, and when it's more than 2 mm, it's called you can say it's mongoloid slant. When it is below the 2 mm, it's called anti-mongoloid slant. Now the normal intercanthal distance, as you know, it's 30 to 31 mm. If the distance is more than that, is called telecanthus. Now we will discuss about the layers of the eyelid. Now the first is the skin. So skin is the thinness of the body is in the upper eyelid. So it's almost the 1 mm to the 0.2 mm. So it's very elastic, and with age it becomes loose and redundant, and it's also, when we age, it's also called as a dermatocalasis. So when this happens, we can use this skin as a skin graft, or for any lid reconstruction surgery or any lid correction surgery. So in skin we have eyelashes, and in upper eyelid we have 100 to 50 eyelashes. In lower eyelid we have 50 to 70 eyelashes. So again, in lid glands we have two types of glands, which is the glands of Leys, which is the largest sebaceous gland, and the glands of moles, which is the sweat glands, which presents in between the the eyelashes. So in this, the inflammations of these glands, which we can call as a sty of the eyelid. So again, the second layer is subcutaneous connective tissue layer. It's devoid of fat from whole body. It's the only layer which is devoid of fat, the subcutaneous layer. It's composed of connective tissue, and during any trauma to this eyelid, it gets easily distended with blood and fluid. So now the orbicularis oculi muscle, which is in concentric fascians, it has two parts. One is orbital part, the second is palpebral part. Again, the palpebral part has two parts. It's the pretarsal and preseptal. So now the preseptal orbicularis oculi muscle has one small muscle which is present in the preseptal area, which is Horner's muscles. How it works is when it closes the eye, the tears will go into the punctum of the eye, and the Horner's muscles will help that lacrimal sac. It creates a negative pressure, and the lacrimal sac will drain all the tears, and it goes through the nasolacrimal duct. Then we have come from the orbital septum. So orbital septum is nothing, it's a extension of your periosteum of your eyelid. So it divides in two parts. One which comes as an orbital septum into the eyelid, it joins into the superior part of the tarsal plate, and again another one which goes into the roof of the orbit or a supraorbital region of the orbital rim. So it functions as a like protection of the eyelid. Also it acts as a barrier, or it separates the eyelid from the orbit. So you can see like the region of the attachment of the levator aponeurosis, which the fibers of the skin determines the height of the eyelid crease. So in Asian, we have a lower fusion of the eyelid crease where the flat eyelid fold or no fold in the Asian eyelids. So in again the European eyelid, we have the lid crease, or which forms above the tarsal plate, which when the periosteal or orbital periosteum and the levator superioris muscle, which joins above the tarsal plate, and it's the position of the crease which measures the attachment of the skin. Again, we have an orbital fat patch. So we have three types of fat patch. One is lateral fat patch, central, and the medial fat patch or nasal fat patch. So in that, the nasal fat patch is different from the central and lateral. Which how you know this, that because the color discoloration, like nasal fat patch has a pale yellow in color, and again the central fat patch, they are like dark in color, dark yellow in color. So levator palpebris superioris, that's the next layer which comes from the apex of the orbit, and it also joins the sphenoid bone, and it comes horizontally till the anterior superior orbital rim. Then from that it transverse as a vertical plane. So it transverse as the levator aponeurosis from that transition zone where there is a ligament called Whiteman's ligament. So it's a main retractor which opens the eye, and it's innervated by the oculomotor nerve. So it's also involved in the ptosis or ptosis repair surgery. So below the levator superioris, you have a Muller muscles. In between the Muller muscles, we have a peripheral arcade artery, so which determines between these two layers. So it's a smooth involuntary muscles which innervated by the sympathetic nervous system, and it also opens the eye. It's about 2 mm of the eyelid. So again, the orbicularis, which is a protractor muscle which closes the eye, the levator palpebral superioris, which retractor of the eye, and the Muller muscle, it's a retractor of the eye again. So again, below the levator Muller muscle, we have again tarsal plate, which is a very thick fibrous structure, or it gives the integrity or the structure of the upper eyelid. It attaches with the medially with the medial tendon or medial canthal ligament, or in the laterally it's connected with the lateral canthal ligament. It is very strong, which also extends till the periosteum. So the length of the tarsal plate is 29 mm, the width is 11 mm. So again, it provides a shape and integrity, and it has a glands called meibomian glands which runs vertically into that tarsal plate, and its function is that it lubricates the eyelid. So it has again it's form a tear film in the eyelid, which again the secreted by the meibomian glands as a lipid layer, again the aqueous layer and the mucin layer. The aqueous layer which secreted by the lacrimal glands, the mucin layer which secreted by the conjunctival goblet cells. The layers of the eyelid, as we have discussed, the first layer which you can see is skin. Now this is your skin. Then you have a orbicularis oculi muscle. Then below the orbicularis oculi muscle, we have a extension of the periosteum, which is orbital septum. Then again orbital septum. Below orbital septum, we have a levator superioris muscle. And below the orbital septum, we have a fat patch. Below fat patch, we have again levator superioris muscle, the white structures you can see. Then again, we have a tarsal plate here, and then again orbicularis oculi, and this is the skin. So this is a lateral fat. So below that lateral fat, which the palpable part of the lacrimal gland, and again here is your central fat, and you can see here, if you go deep, then you will find a nasal fat. So again, when you lift this lateral part of this fat, like lateral fat, you will see below there is a pinkish glandular tissue or a lobulated gland, which is your lacrimal gland. So this is your lacrimal gland below this fat, and above that you have a periosteum and a superior orbital rim. Again, in this same approach, we can also approach the superior orbital rim and the lateral orbital rim. So this is your lacrimal gland. So below that we have a conjunctiva. Below the tarsal plate, it's a very thin layer and it is transparent and posteriormost layer of the eyelid. So it is a very vascular membrane and it's firmly attached to the tarsus. So when you dissect the nasal fat, below that we have connection of the conjunctiva, which sometimes there is two artery, which is medial pulmonary artery, and again the branch of a superior ophthalmic artery, which sometimes may bleed and it goes into the surface of the conjunctiva, and you can see the subconjunctival hemorrhage post-operatively. Then again the arterial supply, which is like the upper eyelid, which is supplied by the frontal artery, the marginal arcade, and again the peripheral arcade. It's the marginal arcade, which is you can locate it in the superior margin, the superior eyelid margin between the tarsus and between the tarsal plate of the orbicularis. So this is your marginal arcade. Again, the collateral branch of the zygomatic orbital branch, the transverse facial branch and superior temporal artery, which again gives the blood supply to the upper eyelid. So the peripheral arcade, which are located within the smooth muscles of the leech and the border of the tarsus.
2 minutes, sir.
The venous drainage, which is the superficial or pre-tarsal system, which drains directly into the external and internal jugular veins. The deep and post-tarsal system, which directly drains into the cavernous sinus. So nerve supply, which the motor nerve supply of the orbicularis is a facial nerve, the zygomatic branch, and again the LPS, the levator palpebral superioris muscles, is supplied by the oculomotor nerve, the thoracic nerve, and again the smooth muscle, which is supplied by the sympathetic nervous system. So these are the sensory supply, which is supraorbital nerve, the supratrochlear nerve, lacrimal nerve, and infratrochlear nerve. So these are the difference. Thank you.